And thank you guys for coming. As Pam says, I've been here for about 13 years, and I started giving these talks when I had just arrived in town. And one of the questions that often came up is, "You're so young, what do you know about menopause?" That doesn't come up as often anymore, unfortunately. But when I started giving these talks, one of the reasons that I started becoming interested in it was because there were a lot of women out there who needed information and not a lot of information. It's become a much more talked about topic since I started giving these talks. Has anybody ever heard me talk about menopause before? Okay, good, actually, because some of it's repetitive. If you've ever heard one of my talks before, I'm going to talk about a lot of stuff about menopause, going through some of the different stages of menopause, some of the different symptoms that are associated with it. I'm going to spend a fair amount of time talking about hormone replacement therapy because people usually have a lot of questions about that, and that's certainly something that I deal with a lot. And it's, of course, very controversial as well. I'm going to try to cover all this stuff with plenty of time at the end for questions because there tend to be lots of questions, and I'm happy to cover anything that, any questions that I can try to answer. I do want to let you know that there's a disclaimer. I did not pick the title of this. Pam picked the title, but it actually fits in beautifully. Are there any sailors in the group either? A sailor or the videographer. Well, I am a sailor, as Pam said, and actually I'm going on a sailing trip in less than a month, so it's perfect. And this is from my last sailing trip. So the average age of menopause is 52. The definition of menopause is actually when it's been a year since your last period, and it's not due to any medical issue. And so it's been a full year. So you're not technically menopausal until you haven't had your period for a year. You know, usually by then a lot of the issues are kind of over. So the issues usually come up way before you're technically menopausal. Perimenopause, the symptoms that are associated with the time leading up to menopause and shortly thereafter, can last up to 10 years prior to this. We're going to talk a bunch about that. And the symptoms and the issues that come up vary according to the different phases, and they're all individual. Women leading up to menopause and going through menopause often feel many different things and don't quite know what the heck is going on with their bodies. And there's good reason for it. This is a very complicated chart that basically shows you, these are all the main female hormones. This is not a menopausal woman. This is a premenopausal, normally functioning woman in her reproductive years. So you can see during the first half of the cycle, hormones aren't doing much, then some of them go up, then they go back down, then they go back up. They're all over the place. And men wonder why we have issues with hormones, because this is a normal month. So you can imagine, as the ovaries stop working so well, stop responding to all the stimulation, don't ovulate as much as we age and get a little closer to menopause, these hormones can get really wacky. And what usually happens is they're so resistant that finally they respond, and then the highs go way up higher. So then, of course, they drop way, way lower. And it's those huge fluctuations in the hormones that often give most women their premenopausal symptoms. Just about every system in the body is affected by estrogen. So there's a reason that there's not just one symptom associated with this. And we're going to talk a little bit about some of these different systems. Some of the things that can happen as you go through menopause, there's some short-term and long-term symptoms. Short-term, hopefully, hot flashes occur. That's one of the first symptoms. Night sweats, sleep disturbances, and mood changes occur. Long-term, there are some disease processes that are associated with lack of estrogen. Urogenital symptoms such as vaginal dryness and bladder symptoms. Cardiovascular disease I'm going to spend some time talking about, and Dr. McFarland is going to talk about that more next month too. And then osteopenia and osteoporosis, bone loss, is one of the things that shows up later, and it can create a lot of problems later in life. And then cognitive decline is definitely associated with loss of estrogen, which doesn't show up usually until the 60s and 70s and 80s. One system that wasn't on there is dry skin. This is from my sailing trip too, but you might feel like your skin is as dry as a lizard. One of the reasons that this has become such a much bigger issue over the last 20 to 30 years it has to do with baby boomers, which actually my next slide shows up a little bit. But also, back before 1900, women didn't really live much past menopause. Since 1900, our life expectancy has gone from somewhere under 50 years old to over 80 years old now. However, the age of menopause has not changed by all that much. So all of a sudden we have all these years of life, often more than a third of our life after menopause, and we have to figure out how to deal with those years. And this is dealing with some of the baby boomer issues. Not only is our life expectancy bigger, but we have a much larger population in this over 65, over 75 age range, and that's only going to get bigger with time. So again, it's a large population of women who are looking for answers for various different issues. All right, continuing on the sailing theme, we're going to talk a little bit about perimenopause. Oh, my mother would die if she knew this picture was in here. So as I was saying earlier, a lot of the symptoms begin when your hormones are starting to fluctuate as your ovaries age and are more resistant to stimulation. Your periods are often still regular, although sometimes they're a little bit heavier as you get closer to menopause. If you remember when you're a teenager and your periods first start, often they're very heavy, there's a lot of cramping, and then in your 20s and 30s they're not so bad. Well, they can tend to get back to that way again when you're in your 40s, getting closer to menopause. And actually, the fact that a lot of times the periods are still regular is one of the reasons why a lot of times women don't know that some of their symptoms are due to perimenopause. It's not uncommon that I have a woman who comes in just for her regular exam, but then she sits down and says, I think I'm going crazy. And mood issues are often one of the first things that show up while the periods are still fairly regular. And it's often due to perimenopause. So what are some of the different things we can think about to deal with this? Well, if the periods are a problem, if they're heavy, sometimes irregular, birth control pills can certainly be an option if you're not a smoker. Smokers over 35, we don't prescribe birth control pills to, except in very unusual circumstances because the risks are too high. But if you're a non-smoker, birth control pills can be used very safely, even up to menopause. I have some women who take them until we know they're past menopause. And it can certainly help with making the periods more regular and not as heavy, and can sometimes help with a lot of the mood symptoms and sometimes the hot flashes and night sweats too. Even if you're getting kind of close to menopause, but your periods are still coming fairly regularly, traditional hormone replacement therapy is not going to help as much. Hormone replacement therapy is very low doses and helps keep you from bottoming out in your hormones, but it doesn't help all those crazy fluctuations. Birth control pills basically takes over your hormones from your ovaries, and that's why it works for birth control, but also why it helps with perimenopausal symptoms. There's a fairly new procedure called endometrial ablation that is becoming used more and more commonly. It's a very simple, sometimes in-office or outpatient procedure where we use a balloon inside the uterus to burn the inner lining of the uterus. And about 40% of women that go through this procedure stop having periods altogether, which women love. But at 90% of the time it's successful at least making the periods much easier to deal with. So that's certainly an option these days to deal with periods. For moods, there's a lot of different options. Sometimes a woman doesn't necessarily need to treat the mood issues, just knowing that that's what it's from can help. But we do use a lot of the antidepressants to help with perimenopausal mood issues. Antidepressants can be used for so many different things, panic attacks, all sorts of different things. But it can definitely be helpful when we're dealing with perimenopausal moods. Even although most people come in kind of wanting a quick fix in a pill form, of course pills have side effects, there are a lot of things that are even more effective for helping moods, including meditation and yoga and aerobic exercise really can make a difference. Now, often if your moods are an issue, you don't really feel like exercising, but it has been shown actually in clinical trials to affect brain chemicals when you exercise regularly, so that can definitely make a difference. All right, now let's talk a little bit about actually going through menopause. My cute husband. He's not really weathering a storm. It's nice and sunny that day, but still. So when you actually go through menopause, your hormone levels fall dramatically. All kinds of hormone levels fall dramatically, but estrogen is the one that causes most of the symptoms associated with it. For most women, they come in and they say, well, how long is this going to last? You know, their periods are becoming less and less frequent. How long is this going to last? I'm having awful hot flashes and night sweats. And for the majority of women, they last about 1 to 2 years surrounding that time when they actually have that last period. Sometimes they last longer, and there are some women that have symptoms their entire life. And when those estrogen levels go down so much is when the health risks that I was alluding to earlier begin. Just to put things in perspective, I wanted to talk about what women think are their biggest health risks. more than a third of women think that breast cancer is the thing that they have to worry most about affecting them from a major health issue. And if you look at these numbers, just about 2/3 of women think that cancers in general are their biggest health risk. And only 7% think that cardiovascular disease is something that they ought to be concerned about. However, cardiovascular disease is going to kill half of us. Heart disease is this big green line of death rates per 1,000 women, and here's strokes, which is this black line. So combined, by far, cardiovascular disease should be your #1 health concern. Down here, we have actually colon cancer. This pink line way down here is breast cancer. And I'm not saying don't be worried about these things, but definitely you need to make sure that you're assessing and dealing with your cardiovascular risks. Okay, let's talk a little bit more about after menopause, and then we're going to talk about hormones and things. Sailing into the sunset, we hope, and avoiding the doldrums. The doldrums, from a sailing standpoint, is when there's absolutely no wind and you can't move anywhere. So, of course, if you're not getting anywhere, you don't want to get into the doldrums. So, again, this is my last sailing trip, and actually there's this rainbow. If you look closely, it was actually a double rainbow. It was really cool. And there's the sunset that we're going to hopefully sail into. Okay, so post-menopause, which starts after that day of menopause, technically, one day. 1 year after your periods cease, a lot of your symptoms start to get better, but vaginal dryness is often getting worse because lack of estrogen makes the skin in the vagina very dry. And although we always talk about dryness, the problem is not just dryness, but the skin in the vagina actually gets much thinner. The tissue gets about 1/10 as thin as it was when there's a lot of estrogen around. So it's not just, although lubricants help a lot of women, it's not just about lubrication, it's also about the tissues themselves. Decline in bone density is a big deal. If you break a hip, the chances of you living on your own a year later are less than half, and the chances of dying within 1 to 2 years of breaking a hip is significant. So breaking a hip is a big deal, and hopefully you're catching some of this before you get to the point where your hips, where you break a hip. And then we talked about the cardiovascular diseases. Okay, let's talk a little bit about hormones. They've been so controversial. And one of the biggest reasons is some of the research that has come out. So I just want to cover kind of a timeline of how this has all gone. Back in the 1990s, there was a trial called the PEPI trial. Everything has a name. The PEPI trial, which was our first indicator, or first clinical study, which really showed what we had thought for a long time, which is that hormones can help decrease your risk of cardiovascular disease. This was more of kind of an observational trial. So then they did a trial called the HERS trial, which was actually taking hormones, and if you were female and came into the emergency room with something that looked like a cardiac event, whether it was just angina or whether it might have been an MI, they put you on hormones, or either hormones or the placebo. But that's what this trial was looking at, taking hormones and actually treating women with hormones to see if it would help their active heart disease. And this study actually gave us some very clear data that showed that when women actually had known heart disease, that starting on estrogen was not a good idea. One of the risks that we know is associated with taking estrogen is it can increase your risk of getting a blood clot, or a DVT. It makes your blood a little bit thicker, makes you a little bit more likely to clot. Overall, that's a fairly small risk, but if you have active heart disease where your blood vessels are very narrow in your heart, which is what can cause the heart disease, and then we make the blood just a little bit thicker, it's actually more likely to precipitate another event in the first year. So in the first year, they actually had more deaths in the women that were on hormones versus the ones that weren't. But interestingly, by the end of the second year, there was no difference in the groups. After the second year, there was actually a decreased risk of deaths in the hormone group. Now, you have to make it past the first year. But after this study, we did not use hormones in women that we knew had active heart disease, and we still don't. But it is interesting to think about, getting a little bit longer out and getting some of the good effects of hormones. Then came the Women's Health Initiative in 2002. And this was the study in the summer of 2002 that made the news everywhere, and women everywhere just stopped their hormones. This study came out saying, actually, taking hormones, not for women with active heart disease, but taking hormones as you go through menopause, if anything, increases your risk of heart disease. And there seems to be that increased risk of breast cancer that we always talk about. So hormones are bad, everybody get off their hormones. Well, it wasn't that simple, although that's what was portrayed. When they actually looked at this data very carefully, this was supposed to be this wonderful, large trial to really prove what the effect of hormones is. But what happened was they didn't recruit enough younger women, women in their 40s and 50s actually going through menopause. They were able to recruit a lot of women who were older in their 60s and 70s who were significantly past menopause. So when they drilled out the data, it turned out that the women in their 60s and 70s did have an increased risk. So they were significantly past menopause. A lot of them probably had some heart disease that they didn't know about, started on hormones when they weren't on hormones before, and had an increased risk of events. When they pulled out the much smaller group of the women in their 40s and 50s, it did actually help protect them against heart disease. So, you know, that part didn't make the media, but the initial part did. So it's not as clear as it looks. I'm going to talk about the breast cancer in a minute, but let's finish talking about the studies that came out. And as in 2004, this was, the E plus P means estrogen plus progesterone, and that was what initially made the news. They used Prempro, which is an estrogen plus progesterone component. If you have not had a hysterectomy and you go on hormones, you need both. The progesterone helps protect the uterus. But if you've already had a hysterectomy and you go on hormones, usually you will get estrogen alone. Okay, so this was dealing with both meds. They hadn't seen those increased risk in the arm of the trial that was looking at estrogen alone. So we got some results from that in 2004. Again, it didn't really make the news. But this trial actually showed us for women with estrogen alone that if anything, there was an improvement in their cardiovascular risk and no increased risk of breast cancer. Again, I'm going to talk about that in a minute. So estrogen alone, if anything, it's not so much that it seems to be safer, but the data is a little easier to interpret to be comfortable with it being safer. So, so it is a little bit easier to counsel women dealing with just estrogen. Nurses' Health study came out that it kind of had some evidence both ways, maybe increased risk of breast cancer, but maybe not the improvement in cardiovascular risk, again, going back and forth. This last summer, the latest thing came out. NAMS stands for the North American Menopause Society, which is a bunch of these academic people that get together and look at all the data to tell us what they think we should recommend for patients. And in August of 2010, they came out with a big statement that said, you know, for women going through menopause who are significantly symptomatic, the benefits definitely seem to outweigh any possible risks, the benefits of taking hormones. So again, this is very confusing. There's a lot that comes out, and we really don't know, of course, what's coming next. Basically, this is a big pendulum that swings back and forth. Should we take hormones? Should we not? And in the end, I think it's a very individual choice. Oh, see, I really was on the sailing trip. That's me. Actually, before I get to most of this stuff, I do want to address the breast cancer issue, because everybody comes in and says, I'm not taking hormones because they cause breast cancer. And it's not that simple. It never is. There are some studies that show us that there may be an increased risk of getting breast cancer if you take hormones. There are just as many studies that show a decrease in risk, and when they average them all out, there's no change in risk. There's a lot of studies out there. It's hard to prove or disprove. So we don't know what the bottom line is. Now, there's a lot of breast cancers that are hormone related, but it's probably more related to hormones you've had in your body your whole life than it is to taking hormones for a couple of years. Breast cancers, from the time that they start as one little cell to the time that they can be detected by any means, takes about 7 years. So anything you do for a few years, especially just for a few years as you go through menopause, could it speed things up? I don't have the answer to that, maybe, but it's not going to cause a breast cancer. At least this is what the experts that I go to all tell me. You know, there are, what I tell patients is there are studies that show an increased risk. I think the worst case scenario is a slight increased risk. There are no studies out there that show a really significant increased risk, although of course that's what you hear. But really, when you look at significant risk, you need to have a risk that is 3 or 4 times. If you do this, your risk of getting this is 3 or 4 times if you don't do this. And that's what the statisticians say. You have to have a relative risk of 3 or 4 to really say, yes, this causes this. Even the worst studies show a relative risk of about 1.6. So it's not even a double risk. So it's real. I know this is a very complicated issue, and it's a very emotional issue. And ultimately, once you assess all that, if it doesn't make you comfortable, then don't do it. But it's not as clear as Matt Lauer will tell you on the Today Show that taking hormones causes breast cancer. All right, some side effects of taking hormones. Sometimes, especially as you're very early in menopause, it can cause you to have a little bit of irregular bleeding. Breast tenderness is very common, mood swings, headaches, bloating, and generally not feeling great, although most of these things are probably more related to menopause, and often these things do get better when you take hormones. The weight gain has question marks by it because the studies actually, although a lot of women say, oh, it's making me gain weight, the studies actually show us that women who go through menopause who take hormones gain less weight than women who don't take hormones. There's a natural, as you age, especially in your 40s and 50s, there's a natural loss of muscle, and muscle keeps our metabolism going. So as you lose muscle, your metabolism slows down and you gain weight, and loss of estrogen accelerates that. So that's also one of the reasons why we tell you to do weight training in addition to aerobics for exercise as you get older. There are lots of different types of hormones, so there are certainly different options, and different women tolerate different ones better. The one that I want to talk about, though, is this bioidentical thing. Okay, Suzanne Summers says that you should take bioidenticals. And again, this is one of the things where the experts all get together. There is absolutely no evidence that there's any advantage of a bioidentical versus something you can get that's prepackaged from a pharmaceutical company. Most of the stuff from the pharmaceutical company, people also ask about, I want to take a natural estrogen. Well, actually, animal extracts are pretty natural. There are some synthetics that are created from a molecule in the lab, but the actual chemistry of them all is pretty similar. And the bioidenticals, there's just that the studies don't show that they are any safer. If that seems to work better for you, that's fine. They are more expensive. They also can be a little less predictable as far as one thing being exactly what you just had. But there's just no evidence that they're any safer or any better for you than anything else. So, and I certainly have patients who do it, and that's what makes them comfortable, and I'm willing to work with them on it. But they are more expensive too. Oh, dolphin! I got to swim with this dolphin. It was very cool. It came up to our boat while we were anchored in one of the harbors. It was very cool. I jumped in the water. It was cool. Let me talk about some other options besides hormones. For hot flashes, the SSRI, there's a lot that's around here a lot. That's antidepressants. It was just quicker to write SSRIs. SSRIs, selective serotonin reuptake inhibitors. That's the big class of antidepressant. That's Zoloft, Paxil, Prozac. There's lots of different options too, but that's just my abbreviation for all antidepressants. Soy, although it's talked about a lot for menopause, the studies actually show that it doesn't make any difference versus placebo. If it works for you, great, but the studies show that it's not really all that helpful. Black cohosh really does help, but here's a secret. The reason is because it's a lot like estrogen. So if you're someone has told you, like if you've had breast cancer and they've said you may not take estrogen, don't take black cohosh either. But black cohosh does help with hot flashes. Progesterone cream, it's made from yams usually, and you rub it on your skin. And that does help a lot, especially with sleep, if you use it at night. So that's something to consider. We talked a little bit about the vaginal dryness already. There are some vaginal estrogens, very little of which gets into your system. So even for breast cancer patients, vaginal estrogen is an option to help with some of the vaginal dryness. Sleep disturbances are very important to deal with. Even if the rest of the time you're feeling pretty good, if you're not sleeping, there's some recent studies that show that it takes years off of your life if you're not a good sleeper. So it is important to make sure that you try to get some sleep, and if you're having trouble sleeping, then there's lots of different options. Again, exercise can make a difference, especially if it's earlier in the day. Sometimes aerobic exercise too close to the time of sleep, when you're going to sleep, actually hurts sleep. And sleep medications are useful when used appropriately. There are some things like cooling sheets that are specifically for menopause to try to kind of draw some of the moisture away from you. So there are other options to deal with this sleep. And we talked about antidepressants already for mood. And then libido is something, although I'm not going to spend a lot of time talking about that, that's a whole talk on its own, but decreased sex drive is, of course, a big thing that happens to women at any age, not just menopause. It's not so easy to deal with because our sex drive is a lot more complicated than a man's. So there's not a female version of Viagra. Testosterone gets a lot of play, especially on Oprah, but the studies have actually shown that for most women it probably doesn't make that much difference. Now, sometimes, though, if a woman has had both of her ovaries taken out, then it could be useful. The ovaries, you know, I was talking about all sorts of hormones going down as you go through menopause. The ovaries also produce a small amount of testosterone, obviously not as much as in men, but the testosterone goes down slower after menopause than estrogen and progesterone go down. So for women who still have their ovaries and going through menopause, especially in clinical practice, I haven't found giving them something with testosterone in it to be all that useful. But for some women who've had their ovaries taken out, so they're having very little of their own testosterone produced, it can be helpful. But in the majority of cases, I haven't found it to be all that useful. Wellbutrin, though, can be useful. It's an antidepressant, but it's not one of these SSRIs. And although most of the antidepressants can actually hurt your sex drive, both for men and for women, they noticed that Wellbutrin did not. So then they took it and they gave it to a group of women who did not need it for any mood reasons to see what it would do, and in a good percentage of them it did help their sex drive. So that is an option, although it's not like Viagra. You can't just take it here and there. You got to take it every day. So that is an option. And of course, if you're having mood issues too, it could help both things. Cardiovascular prevention, very, very important. Come to Dr. McFarland's talk. But as I said, cardiovascular disease is going to kill half of us. So paying attention to this is important. And lipid-lowering medications, of course, if you can do it with diet and exercise, even better. But those statins that kind of sometimes get control of your cholesterol, it can significantly reduce your risk of both heart attacks and strokes that are due to blockages. Preventive aspirin is something that you should definitely discuss with your doctor. There are some studies that show that if you're at fairly low risk, taking aspirin can actually increase your risk of getting bleeding strokes. So it's not for everybody. So definitely discuss that with your physician. But if you're at high risk, then taking a daily aspirin can make a big difference. And the antioxidants I'm talking about are things like fish oils. It can make a big difference. Osteoporosis. Most women should have a bone density by around the time that they're 55 to know kind of where you are in the scheme of things. After menopause, the first down on that scale and your bones are already very thin, then you need to do something to try to prevent it. Weight-bearing exercise is one of the best things you can do to keep your bones healthy. So cycling, although it's excellent exercise, does not count. It has to be walking or running or aerobics. Vitamin D is a big ticket item these days. It seems like every month there's something about vitamin D. Make sure you're getting enough vitamin D. It's supposed to be formed in our skin with sunlight exposure, but we don't get much sunlight exposure, and most of us wear sunscreen too, which blocks it. So make sure you're getting enough vitamin D, and we can test you for your vitamin D level. And then there are bisphosphonates and other medications like Fosamax that can treat it if your bones are getting too thin. There's a whole range of those available now. I've put SERMs up there a couple times. I'm not going to spend too much time talking about that unless you have specific questions about that. But SERM stands for Selective Estrogen Receptor Modulator. These are kind of designer estrogens. And Evista is the first one that came out. And what this does, there are estrogen receptors all over your body, and they're different types. And the SERMs, we know, avoid the types that are in the breast. But they do go towards other specific types. Tamoxifen is also a SERM, and that's used a lot for breast cancer patients or to prevent breast cancer. Again, that's one that avoids the estrogen receptors in the breasts. And sometimes works as an antagonist, shutting down those receptors while it turns on other receptors like in your bones. And Evista in particular is very good for helping your bones become thicker. Dementia is the last issue I wanted to talk a little bit about. Certainly we know with declining estrogen levels that dementia is something that happens, and it happens with aging in general, but speeds up a little bit once you lose estrogen. There was just a study last week that came out looking at green tea and showed that in actually test tubes, they were able to show that substances in green tea decreased amyloid deposits. And anyone who has family members with Alzheimer's may know that amyloid deposits in the brain, again, I'm not an Alzheimer's expert, but amyloid deposits in the brain are what cause Alzheimer's disease. So they were able to show that green tea may actually decrease those amyloid deposits. And then some of the other things on there can certainly help keep your brain healthy. There's also medications, too, for people who are already starting down the early roads for some of those dementia issues. The bottom line is that it's a very complex issue, and everyone is different. So these decisions need to be made individually and depending on what all your issues are, and they change from time to time. So it's something to keep discussing every year. And that's it. Sailing into the sunset. Questions? No questions would be remarkable. Yes.
Is there any kind of genetic connection between what age your mother goes through menopause and the kind of experience your mother has with menopause that you can expect, or if you have a daughter that she can expect? Is there anything like that?
Good question about any kind of genetic connection about what to expect and what time to go through menopause. I don't know that it hasn't really been shown that there's necessarily a genetic connection, but your best guess about what age you might go through menopause is mothers and sisters. Because there's certainly a lot of women that go through menopause at much earlier ages. We don't consider it premature menopause unless it happens under the age of 40, but there certainly are many women that go through it in their 40s, and everyone in their family has. So there does seem to be some connection, although it's not perfect. You know, there's not as much connection as far as the severity of symptoms. That tends to be very variable, even within families.
What about the time you actually start your cycle? Because, you know, with the obesity thing now, you're starting to see a lot younger kids going.
Well, it's not even just obesity. We don't totally know why girls are starting their periods at younger ages, but we definitely see it. And it doesn't seem to have affected, well, maybe the problem is that we're not, whatever environmental factors there are that seem to be having, you know, who knows, hormones in foods we eat. We really don't know. The experts really haven't figured that one out. But it does, whatever those environmental factors are, don't seem to be affecting the age of menopause at all. Whether it will affect the age that those girls go through menopause is too far off to be seen. But that the average age of menopause has changed very little, even over the last 10 or 20 years. Well, calcium is certainly important. Your maximum bone density is at age 30. So unfortunately, we're all on the other side of that. But you know, so certainly it's very important to get our young women to make sure that they're getting enough calcium. So the rest of your life, you should certainly, and there's different age ranges as far as how much calcium you should get, but it's usually between 1,200 and 1,500 milligrams a day. The best way to get calcium is in your diet. And you're talking about 3 to 5 servings of dairy per day. That's not always doable for a lot of people if you're not a big milk drinker or if you can't tolerate dairy. So there's certainly many supplements out there. And there's a lot of debate about oral calcium versus this calcium. And the endocrinologist who just left, unfortunately, Dr. Doerr, who's really an expert in this, told me, you know what, it really doesn't matter. Just get your calcium. And some calciums can be very constipating, the supplements. So sometimes you have to try different ones, you know, but I mean, Tums has calcium in it, so you know, and that doesn't tend to be as constipating. But everybody tolerates different ones. But it is definitely important to get your 1,200 to 1,500 milligrams or 3 to 5 servings a day. And calcium is really the building block. So it's not going to help you build your bones back up, but if you don't have calcium, you're going to speed up the decline in those bones. Yes, Pam?
I'm not speaking about myself here, but I know in some people go through menopause, they feel like they want to have a lot of glasses of wine. And I'm wondering if there is something about an impact of you know, kind of self-medicating through menopause with drinking with alcohol that's a negative that you might want to speak to. Because I know that when I get together with, well, I don't get together with my kids,
Sure.
It's really terrible. I'm just curious as to if there was some kind of, negative impact of alcohol at that time while you're going through menopause that you might want to address.
Sure. Well, certainly over-medicating yourself with alcohol at any point is a problem. And for women, and it seems to be, have a greater effect at lower doses for women than it does for men. The equivalent of 1 to 2 drinks per day is a maximum. Above that, you start to increase your risk both for liver disease but also for breast cancer. That's been shown if you're drinking more than that. But a glass of wine every night has certainly been shown to help your cholesterol and prevent heart disease as well. Now, red wines in particular tend to increase your hot flashes. The tannins seem to make your hot flashes worse sometimes. So I have a lot of patients who switch, to white wine or mixed drinks or beer or something. But you really binge drinking, also going out and popping down, a couple of bottles of wine with a couple of friends on the weekends actually is worse for women too. But that's of all ages, not just menopause. But the biggest thing is, of course, if you're feeling like you need more wine as your medication during that time, you got to watch out. But it can increase your hot flashes. So if you're having more, you might try decreasing, especially the red wine.
What about the grape juice? They say if you don't drink wine, to substitute grape juice, red grapes if possible.
Yeah, but it's not as good for you, and actually grape juice has a lot of sugar in it too, which is worse for you. So know that and actually the whole thing with preventing heart disease and cholesterol, it came out first with red wine, but it's true of all alcohols. But the grape juice does not have the same effect. Although I love grape juice.
You said something about tannins. There's a lot of tannins in tea, isn't there also?
It's different kind of tannins though. And tea in general has a lot of different components to it that are in general pretty good for you. The green tea is kind of the latest thing, but even the black tea has, in addition to caffeine, has other things like methylxanthines that are good for asthma and stuff. So, but it does not seem to increase the hot flashes more so than anything else.
And I didn't read the whole magazine, but there's now something out that's red tea that's good for you.
Yeah, I don't know either.
Magazine yet to see what the red tea was supposed to do for you. I'd never heard of red tea.
Yeah, no, that's a new one on me, but it wouldn't surprise me. It seems like there's always something new.
Is there anything you should limit when you're in menopause? Because it seems like in the old days it used to be, it's a disease or it's something, and it's really just a cycle of life. But is there anything, like if you're an extreme athlete, are there any things that, as you're in menopause that you should say, well, maybe I should wait till I'm over with this before I get involved in this extreme sport or something like that?
Not really. There really are no limitations. I actually as I was putting together this presentation, I pulled together some of my old presentations, and one of the things I used to have was a slide that talked about kind of, endocrine diseases and how we deal with them, because, if you don't have thyroid hormones, you give yourself you take thyroid hormones. If you're a diabetic and you don't have insulin, you give yourself insulin. I mean, with shots, but but menopause tends to be one of the states where some of our glands are failing that we don't routinely replace what it was giving. So in some ways it is a disease state, but no, there's nothing like that you really need to limit. It just depends on your symptoms.
I'm not a medical person, so maybe the only person that doesn't know the answer to this, but the periods, is that the start and finish line? I mean, is that when you know if they're becoming less frequent, and that's when you're really starting to enter the peri?
Well, actually, it can be a little confusing because sometimes as you're getting really close to menopause, the periods actually get a little closer together. There's not one certain way that women go through it. I will tell you that the most rare way that women go through menopause is to have periods like clockwork and then one day stop having their periods and never have another one. Most women are somewhere in the middle where they might skip a few months and then have a few more. And if you've skipped a few months, sometimes the first few coming back are really heavy or long. But sometimes they're closer together as those hormones are fluctuating more before they stop altogether or spread back out. Yeah.
Is there some in their blood test or something that they can tell what stage?
Oh, good question. Good question. There is not a blood test that can tell you what stage you're in. The hormone levels, the problem is that like that early slide where your hormone levels are fluctuating all the time, it depends. In order to truly know, you'd have to take almost hourly hormones for blood tests for a month to really be able to tell. So they're not all that helpful. There is a blood test, the FSH is the test that people use that's the opposite. It's a stimulatory hormone. So when you're really through menopause, the FSH is really high because your pituitary that produces those stimulatory hormones is trying really hard to stimulate those ovaries, and they're just done. So that test is really high. The thing is that usually by the time that test is really high, you know you're menopausal. Now, if you've had a hysterectomy and you don't know for sure, your symptoms are kind of, not classic, and is this menopause? Is this something else? That's when it's most useful. Because then, you're not having periods, so you don't know what your periods are doing. So that can be very helpful. And sometimes we do it just to kind of give us some kind of a clue, but it's not cut and dried. Back to the bioidenticals too, one of the things that drives us a little bit crazy is that you can go to the pharmacist and they'll do these saliva tests for your hormone levels. Those have also never been shown to be all that accurate because they're supposed to fluctuate so much. But pharmacists are not allowed to do blood tests. So some of them, they're allowed to do saliva tests, so some of them use that as some kind of a guide, and okay, so they're somewhat helpful, but they're not all that helpful. So there's not a perfect test, but sometimes the results of the hormone levels can kind of give you some idea that's just not as clear-cut as we'd like it to be.
I'm one of those people that was very early menopause at 37. Don't be jealous. And then just totally quit. Went to the doctor because I hadn't had a period, and I thought, well, this is weird, And by looking at my vagina, he could say, oh, it looks like you're definitely menopausal. And then they did the blood test, and certainly I was. But is it a way that the doctor can normally tell just by looking when they do an exam?
Well, especially in a case like that where you were younger, that's premature menopause under the age of 40. That's certainly one of the things we think about if a woman comes to us and hasn't had her period in a year, but there's so many other things too at that age that, and some of the other things, the one very low estrogen state that could do that would be premature menopause. Everything else, all the other things that could cause you to not have your periods would not be low estrogen states, and what he or she was probably seeing as they looked in the vagina was this atrophic vaginitis, where the skin of the vagina is very pale and dry and looks different. And so that we can tell. Now that is usually a post-menopausal thing, once it's been a while since your body's had estrogen, usually several months at least. So for women, again, who are kind of in the throes of going through it, it's not as helpful. But yes, there's definitely a different look to the vagina when we look in after menopause. Actually, that brings up another point, too, which is, given all this controversy about hormones, and, most professionals kind of tend towards one side or the other, pro-hormone, anti-hormone. I tend toward the pro-hormone side, although they're not for everybody, but I get women who come in and are miserable. I'm like, but I didn't want to take hormones. I'm like, you have got to take hormones at least for a little while. Some women, you just give it up. But all the experts, even the ones who come down on the anti-hormone side, agree that if you go through menopause significantly before the age of 50, you should be taking some hormones at least for a while, because of the significantly increased risk of both heart disease and osteoporosis, that otherwise those risks go up significantly. So certainly for women who are significantly under 50, either if you have a hysterectomy and get your ovaries out, or if you spontaneously go through menopause at a very young age, that hormones should at least be taken for a while. Yeah.
How do you know when you can come off hormones?
I'm sorry, how do you know?
When you can come off hormones.
Oh, that's a tough issue. How do you know when you can get off hormones? There's no way to know except to really try. Some women, and this is something that I deal with every year if someone's on hormones when they come in for their annual exam. Okay, are we going to keep going on the hormones? Some women, honestly, were so miserable before they went on them, and they say, can I just keep going? And we say, given all their risks, we say, okay, that's fine. But other women, take them for a few years. There's not a perfect number of years that we know are safe or not safe. So, some women take them for a few years, and then, kind of are feeling better and say, let me see how I do off of them. And often we'll wean them off. Sometimes if they're on a really low dose anyway, sometimes we'll do every other day for a couple of weeks and then go off. And even women who are going to do well will usually have a temporary period, maybe a month or two, where their symptoms are worse again, and then they'll get better. So that would be, I mean, if you try to wean off of them and your symptoms are only bad for a month or two and then you feel better, then that's an indication that you're through the worst of it. But you still have to pay attention to the other risks as well, especially the bone and the heart disease. Yeah? Even if you've had a hysterectomy. If your ovaries are still in place, at some point those ovaries are going to stop functioning. And although we use the periods as the definition of menopause, truly it's when the ovaries stop working. If your ovaries were taken out, then that was technically menopause, but again, most women are going to take some estrogen, especially if they're younger when that happens, and so that if you keep taking your estrogen, you won't ever get these effects.
So what's the recommended if you're after 50? So like I had my hysterectomy when I was 43, and I'm still on estrogen, well, very low dose.
Yeah, when do you come off of them? That's a good question, and the answer is maybe never. I have a lot of patients who take them forever, including my mom, who's not actually a patient, but I mean, so there's a lot of good things that they do, and it's hard to know when that is. And then with estrogen alone, I don't know if you were here early on when I was talking about estrogen versus estrogen plus progesterone, but with the estrogen alone, the studies, the one really good study that looked at estrogen alone actually, if anything, showed a slight decrease in breast cancer, as well as some of the other stuff like heart disease. So it's a little easier to say that for most women the benefits are going to outweigh the risks with estrogen alone. So it's really an individual choice. There's not a perfect answer. Initially, when all this Women's Health Initiative stuff came out, they said the safe time seems to be 5 years. And most of us kind of said, where are you getting the 5 years from? And the answer was nowhere. They pulled it out of the air. Said 5 years sounds good. I mean, literally, that's what they did. So, that 5 years, it's not a perfect answer either. So there's not a perfect answer to that question. But, if you're taking them mostly for symptoms, then for a couple of years and then kind of see how you do. But there's certainly a lot of other health benefits to them, too, and it's always a balance of where you're going to weigh. Yeah?
What if your hormone levels are normal, but you still have the hot flashes?
Well, it depends, because sometimes it can be due to those fluctuations in hormones. So even if at one certain moment you take the blood and your hormone levels are normal, then it can be due somewhat to the fluctuations. But I have women who are clearly not menopausal. Some women who are on birth control pills, for instance. And if you're on birth control pills, you're getting enough hormones that any hot flashes you get are not due to hormones. So I do know that some women get them for other reasons. Some women can just be kind of hot-natured. Certainly, sometimes it's weight-related, but sometimes it's not. And some women just kind of get them, and we don't totally understand. We don't really know what hot flashes are from, other than they're related to hormones. But we don't really know the physiologic mechanism of them. But definitely some screw up in your internal temperature regulation. Hot flashes tend to be worse in the fall and the spring. When you're at home and some days you have to turn the heat on and some days you have to turn the air conditioning on. That's when the hot flashes tend to be worse because your internal air conditioning doesn't quite know what it's supposed to do either. But again, we don't truly know the mechanism of hot flashes, and they're probably not all the same thing. So it could either be that hot flashes are due to some of that fluctuation, or it could be that it's due to something else entirely. Mm-hmm. But other things can do that. Yeah?
I wanted to ask, I've been off of estrogen now for about maybe 12 years. And since then, it seems like my body's been going downhill. And I've had a hysterectomy, my ovaries been removed before then. But I was just wondering, would it be a good idea to get back on estrogen? Because I've had like thinning of my hair, the very dry skin, eczema, just one thing after another. And I was just wondering about, would it be a good idea to go back to the estrogen?
That's a really good question. Going back to estrogen 12 years later. I would say that that's the one big thing that all of us took out of the original Women's Health Initiative, was because those older women seemed to have a lot more increased risk when they had been without hormones for a while and then restarted them. For women who have been without hormones, well, let's put it another way. For women who have been without hormones for less than 10 years, certainly less than 5 years, whether it's going through menopause, having a hysterectomy, or off their hormones because someone, they decided to stop them but they want to restart them, then I'll certainly consider it. But if it's been more than 10 years, I don't recommend it. And the reason I use 10 years as that kind of cutoff is because there's some good studies that show that when men tend to have bad heart disease starting even in their 40s and 50s. And for women, it's not usually, again, there's exceptions, but not usually until about age 60. And when you look at the studies, clearly it's about 10 years after menopause that our risk of heart disease is equal to men's. And so 10 years is kind of that magical number for me. If it's been more than 10 years without hormones, I don't recommend restarting them.
Do her problems possibly be thyroid?
Oh, thyroid is definitely, a lot of menopausal symptoms, and usually when we're checking hormone levels and kind of trying to decide, a lot of menopausal symptoms are similar to thyroid symptoms, including hot flashes and night sweats and dry skin, thinning hair. So certainly, make sure you get your thyroid checked to make sure that that's where it should be. Yeah, so if that's where it should be, still a lot of those things could be, due to lower estrogen levels, but I wouldn't restart. Yeah.
But sometimes your thyroid levels are within the limits too.
Yeah.
So they won't treat you for the thyroid, but you
Right.
still have all the symptoms.
Yeah, unfortunately, there are some times where there's just stuff that we don't know what the cause of it is. And unfortunately, we can still only look for the things we know to look for.
And then sometimes it's working with an endocrinologist, I found, seems to know a little bit more and will not just go necessarily by, oh, you're within normal range, simply because they don't understand as much about it, and they'll have a tendency to lean more with your symptoms and maybe
Right.
helping things.
And that's true, and actually, especially with the thyroid stuff, the current levels of the normal for TSH, which is the thing we use for thyroid, is actually up to about 4.5, but really they're probably getting ready to change those more to like 2.5. So if you're in that normal range, but it's high normal, then, I'll sometimes treat if someone's symptomatic. So, and we are getting a new endocrinologist here. Yes, since our endocrinologists have left, but there are at least one new one coming just within, I was going to say within the next month or two, and then they've got at least one, maybe two others in the pipeline. Anything else? Thank you guys for coming. I appreciate it.